Hello and welcome to the class today. My name is Negedu Agada Godwin and I'm your regular uncle. Before we begin, please like, share, subscribe and put on the notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or you can WhatsApp me at +234 9019 144 or you visit our online store at sonoeyes.business.site. Attend the quiz in the description and leave me a comment. You're welcome back. Today we're going to be discussing pancreatic anatomy. Now the pancreas is a non-encapsulated structure. In other words, it does not have a fibrous thin sheath covering it, and it is a retroperitoneal structure that lies transversely or somewhat obliquely in the anterior pararenal space between the C-loop of the duodenum and the splenic hilum. Total length from the head to the tail of the pancreas is 12.5 centimeter to 15 centimeter. The pancreas is draped transversely over the spine and great vessels. So it's draped transversely but anterior to the spine and the great vessels, which are the IVC and the aorta. The anterior surface of the pancreatic body borders the lesser sac, which is a potential peritoneal space. The stomach is just anterior to the lesser sac. The pancreas is divided into the head and the oxygenate process, the neck, body, and the tail. The head lies to the right of the spine, anterior to the IVC, with the C-loop of the duodenum that is formed by the superior descending and transverse portion. Anterior to the head is the pyloric portion of the stomach. The gastroduodenal artery denotes the anterolateral border of the head, while the common bile duct marks the posterolateral border of the head. So the superior mesenteric vessel, usually the superior mesenteric vein only, lies anterior to the uncinate process. This uncinate process is the medial tapered projection of the head that extends posterior to the superior mesenteric vein and sometimes large enough to extend to the posterior of the superior mesenteric artery. The neck is a portion of the pancreas that lies anterior to the superior mesenteric vein and the origin of the main portal vein that is known as the portal confluence. The body extends to the left of the neck and runs transversely in the midline of the upper abdomen anteriorly to the splenic vein, superior mesenteric artery, and the abdominal aorta. There are no anatomic landmarks that separates the body from the tail. The left border of the vertebral column is an arbitrary plane for dividing the body from the tail. The tail extends across the left adrenal gland and upper pole of the left kidney to end near the hilum of the spleen. It is most commonly found at or near the hilum of the spleen, usually. However, it may lie low in position near the upper pole or the hilum of the left kidney. The normal pancreatic duct also known as the main pancreatic duct, or MPD, or duct of Weisung, starts in the tail and extends along the mid-body of the gland into the head, where it turns downward and backward to approximately the infraduodenal portion of the common bile duct. The mean internal diameter of the main pancreatic duct measures 3 mm in diameter in the head. It measures 2.1 mm in the body and 1.6 mm in diameter in the tail. Occasionally, an accessory pancreatic duct that is called the duct of Santorini may be visualized in the upper anterior part of the head. When present, it opens into the duodenum via the lesser duodenal papilla, 2 cm more proximal than that of the main pancreatic duct. Now, look at the dimensions of the pancreas. The size will vary with variable shapes of the pancreas and variation in age also. The accepted normal AP measurement in adult pancreas are: the head will be within a range of 2.5 cm to 3 cm. The body range from 1.8 cm to 2.1 cm. The tail is from 2.1 cm to 3 cm, while the main pancreatic duct is 1 to 3 mm in diameter. Pancreatic vessels and ductal landmark are very important for us to look at in its anatomy. The accurate localization of the pancreas relies upon the knowledge of the relationship of its surrounding vessels to the pancreas. These vascular landmarks must be appreciated in both the transverse and the longitudinal plane. Like we've always said, you do your examination in 2 planes, transverse and longitudinal. Let's look at the landmarks for the head and the neck. Beginning with the IVC, pancreatic head lies directly anterior to the IVC, inferior vena cava, and terminal portion of the renal veins. In sagittal section, this level is just inferior to where the main portal vein crosses the IVC. A mass in the pancreatic head or swelling of the head in an acute pancreatitis may compress and occlude the IVC. The common bile duct, as a landmark, it arises in the hepatoduodenal ligament from the union of the common hepatic duct and the cystic duct. It is located anterolateral to the main portal vein and courses inferiorly towards the head of the pancreas. It is important. It is actually an important landmark to delineate posterolateral. That is a very important landmark that delineates the posterolateral border of the head. The distal common bile duct is located just anterior to the IVC. Gastroduodenal artery arises as a branch from the common hepatic artery and descends inferiorly within, or it marks the anterolateral border of the head of the pancreas. The superior mesenteric vein ascends from the lower abdomen parallel and to the right of the superior mesenteric artery, and it joins with the splenic vein to form the portal vein, as a portal confluence, just anterior to the uncinate process of the pancreatic head and the posterior to the neck of the pancreas. Hence, the uncinate process is located just posterior to the superior mesenteric vein. The superior mesenteric vein also defines the posterior surface of the neck and serves as a landmark for medial border of the head. A mass arising from the uncinate process or a regional lymphadenopathy may displace the mesenteric vessel anteriorly. Let's look at the landmarks of the body and the tail. The ciliary trunk and branches. The ciliary trunk arises from the anterior surface of the aorta, usually just superior to the body of the pancreas. Immediately, it gives off three branches: the common hepatic artery, splenic artery, left gastric artery. The common hepatic artery courses transversely to the right and in the region of the pancreatic neck. It divides into two proper hepatic artery and gastroduodenal artery. The posterior hepatic artery courses superiorly towards the porta hepatis, anteromedially to the main portal vein. Gastroduodenal artery courses inferiorly within or along the anterolateral border of the head. The left gastric artery is small and usually cannot be identified by ultrasound, so you may not want to take too much time looking for it. The splenic artery arises from the ciliary trunk and courses in a tortuous fashion towards the left along the posterior superior surface of the body and the tail of the pancreas. It is located just superior to the splenic vein. It is easy to find in transverse section. Of course, the splenic vein originates at the splenic hilum and courses to the right, directly posterior to the inferior border of the tail and body of the pancreas. It joins with the superior mesenteric vein posterior to the neck and the anterior to the uncinate process to form the main portal vein. The splenic vein is the main landmark to localize the posterior surface of the inferior border of the body and tail of the pancreas. So when you look at the splenic vein, it basically delineates the posterior border, and that's a good landmark to begin to find the pancreas. So let's look at the pancreatic physiology in a quick peek. The pancreas is a mixed gland with both the endocrine and exocrine components. The exocrine secretions are produced by the cells that are called the acini. The acini liberates their secretions into the pancreatic duct. The volume of exocrine secretions produced in the acini cells range from 800 to 1,200 mL per day and contains at least 9 digestive enzymes. It contains water, bicarbonate, and salt. In the duodenum, the enzymes take part in the breakdown of protein. It also takes part in the breakdown of carbohydrates and fat and help to neutralize acidic kind that comes from the stomach. The main exocrine pancreatic enzymes are amylase, which aids in the digestion of carbohydrates, lipase, which can complete the digestion of fat, trypsin and chymotrypsin, which aid in the digestion of protein. The endocrine secretions are produced in isolated islands of cells that are called pancreatic islets, or the islets of Langerhans, which are liberated into the bloodstream and carried throughout the body. The beta cells in the islets of Langerhans produce insulin, and the alpha cells in the islets of Langerhans produce glucagon. Besides, there are delta cells which produce somatostatin. There are discussions around insulin, glucagon, diabetes mellitus, and so we will not cover that in this discussion, but it's important for you to know. A quick view at the laboratory tests for pancreas. So with few laboratory tests, you can have a serum amylase. A highly elevated level of the serum amylase would indicate acute pancreatitis. That can be an indication for the ultrasound in the first place, or if you actually did a scan before the test, you may want to be suggesting that test. Moderate elevation is usually seen with obstruction of the pancreatic duct. Pancreatic cancer could cause moderate elevation, and acute salivary gland disease also. In acute disease, it rises very fast within 4 to 12 hours and thereafter falls back very fast to normalize within 48 to 72 hours. Other tests include urine amylase. Serum amylase falls very fast, but urine amylase will persist for 7 to 10 days. Therefore, this test can be used to diagnose acute pancreatitis after 72 hours when the serum amylase has been subsided. You can have depressed level of urine amylase, which will occur in chronic pancreatitis. Serum lipase will be high in level, and you see that with acute pancreatitis, and can remain elevated up to 14 days. And other enzymes like serum amylase, serum lipase levels that do not rise with chronic conditions of the pancreas because the cells have been destroyed by underlying conditions. So both serum level rise with pancreatic pseudocyst and pancreatic duct obstruction. Persistent elevation in the absence of renal disease will suggest pseudocysts. Yeah. GTT, that's glucose tolerance test, is performed whenever there is disorder involving the sugar metabolism is being considered. So you have 75 grams of glucose administered orally to a fasting patient, and blood glucose level will be monitored. Normally, it will return to fasting level within 2 to 3 hours. And abnormally, the persistence of the elevated blood sugar level for 3 hours is diagnostic for diabetes. So we should have a value of greater than 7.8 millimoles per dl. Alright, sonographic appearance of a normal pancreas. I haven't understood the anatomy. The pancreatic parenchyma has an homogeneous texture, but coarser than that of the liver. Its echogenicity is slightly greater than that of the liver, of course. The size and echogenicity of the pancreas varies with age and obesity. The pancreas normally atrophies with age, so the size gradually will decrease as the individual is aging. In children, the pancreas may be significantly larger than the normal adult measurement, whereas in elderly, it may be reduced by thin strip of tissue which is heavily fibrosed with mildly dilated main pancreatic duct. Hence, in children, the pancreas is less echogenic than in the elderly, since fibrous pancreas is highly echogenic, right? In the obese patient, the pancreas is also very echogenic because the pancreas has no capsule, and the retroperitoneal fat may infiltrate the gland, resulting in a more echogenic pancreas. That's actually the reason why obese patients will have echogenic pancreas. Not necessarily a pathology, but just an underlying occurrence. In some obese patients, there may be a focal area of decreased echogenicity in the background of a highly echogenic pancreas. This is thought to represent area of focal sparing in the gland. in a gland that is diffusely infiltrated by fat. So a very simple and quick scanning technique. The pancreas is interrogated in transverse and sagittal sections. To image through the long axis of the pancreas, the transverse section will have to be oblique so that the plane is lower to the right of the patient midline and higher to the left. Yeah, you position your probe in that way because the pancreas is not parallel, it's oblique angled. Often you will have problem with bowel gas overlying the pancreas, of course, and also gas from the stomach. So how do you overcome these challenges? You overcome it by inspiration, by expiration. You distend the abdomen against the probe, ask the patient to push their stomach out. Yeah. You give the patient oral water, like let's say 2 to 3 glasses of water. The water will be used as a window to look through when it is in the stomach and the duodenum. So that is the stomach is a acoustic window for the pancreas. So you can also overcome that by scanning the patient standing erect, so that gravity will drag down the bowel and its gas, so that you can view. The head of the pancreas, if you want to visualize it, you use both transverse and sagittal placement of your probe, as the head can be quite long and continue caudally for several centimeters. The body of the pancreas on transverse scan are obtained in a sequential order from superior to inferior border. Use the splenic vein to help identify the pancreas superficial to this, yeah, because the splenic vein is a marker for the posterior border. The tail of the pancreas will start. You want to start your probe transversely, then you angle the heel of your probe cephalad and also left, as the tail can be sitting up under the spleen. Thus the spleen can be used as a window also, and a coronal approach can also be utilized. There, so you have several windows you can use for the spleen, the superior mesenteric, the splenic vein. You can use water in the stomach. You can use the spleen as a marker. So basically, when you do your documentations, document normal anatomy. Any pathology found should have been discovered in 2 planes, and also include measurement and any vascularity you see when you are making documentations. So this image shows you the scanning planes for a live patient and also the ultrasound image. So this is transverse, and that's how you place your probe, and that's what you see on ultrasound. And longitudinal plane, this is how you place your probe, and this is basically what you see on ultrasound. You will be seeing head of pancreas in longitudinal plane. And these are images. The transverse view that demonstrates the pancreas. You can see P represents the pancreas, while the splenic vein is represented by S. Yeah. Then in this image, you have the pancreas with the arrow pointing at it. You see the aorta, you see the stomach labeled ST, and GDA with the longer arrow. And these are also images to show you the pancreas in this image is actually a wedge shape or triangular shape. You can see in this other image, the pancreas with the arrow, with the thick bold arrow pointing at the pancreatic duct. Now in this particular image is an image from an elderly patient. It's markedly echogenic, becoming essentially isoechoic with the fat at the root of the mesenteric which surrounds the superior mesenteric artery. You can see the superior mesenteric artery is the black arrow. You can see it's isoechoic to the fat around that area. This is a consequence of replacement of glandular tissue with fat and represents a normal aging change. With that anatomy, we are now ready to face the pancreatic pathology in ultrasound. I want to thank you for joining this lecture. Please remember to like the video, share, subscribe, and put on notification to receive all our free lectures. For more information about our paid classes, please send an email to sonoeyesdiagnostics@gmail.com or WhatsApp me at +234 9019144175. You can visit our online store at sonoeyes.business.site. Attempt the quiz in the description and leave me a comment. Until the next time when I come your way again, keep learning ultrasound.